Hi everyone, my name is Mustafa Yousif, and today we'll cover artificial intelligence applied to breast pathology. Here's a little bit about me. I am assistant professor and informaticist at the University of Michigan, Michigan Medicine, and also serve as a clinical director of digital pathology. I also serve as a co-chair of the DICOM Working Group 26 and as a board member of the Association of Pathology Informatics and the Digital Pathology Association. And here's my disclosure. And here's the outline, which will cover some introduction about digital pathology and some definition about machine learning. And when we will dive deep into the AI algorithm of the breast cancer detection, classifications, and other applications in breast pathology. And then we'll move into key considerations for AI or building AI in pathology. We'll cover some lab interoperability issues as well as what is the pixel data in medical imaging and how to handle it, and finally the lessons learned and conclusion. So before we dive into digital pathology and machine learning modules, I would like to emphasize there are an extensive steps in order to prepare that glass slide, and those steps starting from accessioning the patient and everything in pathology. As we all know, it's a specimen level, not patient level in the beginning. So after you accession, then you will receive the specimen and you are preparing the specimen, called grossing. And then after grossing, there is a extensive processing and embedding, and after that sectioning of those ribbons and different type of staining and glass preparation, maybe different type of processing even with glass preparation, and finally delivering those glass slide to make diagnosis and archiving. And after all those steps of preparation of the glass slide, those slides will be assembled on those trays, and then after the slide assembly as well as case assembly and organization, then they will be distributed or delivered by multiple personnel to the pathologist, and the pathologist will start reviewing those cases under light microscopy or different other immunofluorescence microscopy, and then start preparing the report in the lab information system, and the lab information system will push the report to the electron medical record for patient review or patient receiving their path report, as well as to the clinical provider. And the difference between the analog and the digital, those slides are digitized in a specialized scanner, and then after those digitization, the images will be assembled or organized by a specialized platform called Picture Archiving and Communication System, and then those systems will send the images to the digital display by the request of the pathologist, and then the same thing, the lab report will be prepared by the lab information system and sent to the EMR. And those digital images are in the what's called the pyramid format, which is technically the sensor and that scanner start taking those images tile by tile at the highest resolution, which is sometimes also in multi-frame images, and then it will assemble all these images and stitch all these tiles to get this what's called pyramid format, or the whole slide image. And I would like to share with you the case management workflow, which is technically the ideal workflow when the images are assembled in this PACS platform and the pathologists start reviewing those cases digitally, clicking on every single case, open multiple windows to review the image as well as trying to type the report. But the most important thing is those packs or platforms has to be integrated or provided what's called a tool for a third-party solution or machine learning application, AI tools, to receive those digital images. So if you don't have this functionality, then it's really limited. So you have to have a platform to send those images or send an instance of those images, and the AI tool will receive those instances and start apply the analysis and provide back the annotations or results to the image viewer or PACS, so the pathologist can have a computer-aided diagnosis to review all these annotations and heat map and etc., which we're gonna discuss about it. So, the definition of machine learning refers to the development of computer systems capable of performing tasks that typically require human intelligence. In medicine, most applications labeled as AI fall within the category of the narrow AI, where machine learning modules are specifically trained for limited tasks by identifying patterns and relationships in the provided data. And also, the American Medical Association, along with the other professional medical society, advocates for redefining AI as augmented intelligence rather than artificial intelligence. This distinction emphasized that so far no automated systems have replaced the physicians or the pathologists, and instead, most machine learning models are designed to enhance human intelligence and provide support rather than functioning independently of human oversights. So just to give a general workflow about the AI-based image analysis in pathology. We mentioned a couple slides ago that you have multiple steps of tissue processing, and also you have multiple types of sample type or specimen type, like biopsies, resection, formalin fixed, paraffin embedded versus for frozen section. And then all these images after are generated, maybe they are divided into patches, and after those images then processed through various deep learning architecture, which meticulously learn and extract intricate features from smaller image patches. Central to this process is the convolutional neural network, where convolutional layers apply specialized filter to the input, capturing hierarchical patterns through successive convolutional operation. To manage computation demands, pooling layers subsequently downsample the spatial dimension of the data, effectively reducing the complexity while retaining essential information. Ultimately, the carefully selected features derived from the sophisticated analysis are employed to deliver accurate slide level diagnoses, bridging the gap between the digital pathology and advancing AI driven insight. So there are multiple steps for the image analysis. It starts when usually for the patches generation. After those patches are generated, it can be, there is a pre-processing steps such as color normalization, which is often applied to account for any variation in interlaboratory H&E staining or other lab protocols. This color normalization helps address pre-analytic artifacts such as inconsistency in the H&E staining or even in the scanner color calibration. Annotated images or ground truth labels serve as a reference standard, providing the data needed for training model to predict specific outcomes. And these labeled datasets are used to train downstream models for tasks such as detecting or segmenting different classes. Once the model can detect, localize, or segment each class, the result of the data can be used for quantification. And also, here the distinction between the segmentation and detection lies in their output. So, detection involves identifying objects with bounding boxes, whereas segmentation focuses on specific pixel representing a particular class within the image. Machine learning models, also in pathology, have been applied in various tasks, including image classification, nuclear, cytoplasmic, and membrane segmentation, and also rare event detection, mitosis, and microorganism detection. Now we will dive deep into the AI algorithm for breast cancer detection, classification, as well as tumor identification, tumor grading, biomarker status, response to treatment, and survival analysis. So for tumor identification, there are multiple challenges have been done in the past. And I'm sharing with you the Grand Challenge, which is a platform dedicated to organizing and hosting medical imaging competitions where researchers, clinicians, and data scientists collaborate to develop and evaluate innovative solutions. That include detection of mitoses, a breast cancer metastasis to lymph nodes, lymphocyte and tumor infiltrative lymphocyte detection, and quantification of breast cancer cellularity. These efforts also extend to patients receiving neoadjuvant chemotherapy, automating the measurements of residual tumor cellularity relative to the tumor bed area. Among its initiatives, Grand Challenges have focused on leveraging deep learning algorithms for the automated detection of metastatic breast carcinoma and whole slide images. By providing identical datasets to all participants, these challenges attract groups from various organizations and institutions, enabling fair comparison of tissue segmentation modules that ultimately facilitate lymph node classification. Here I'm showing you example here at this side where lymph nodes with macro and micro metastases of breast cancer detected by a deep learning module indicated by the yellow outlines, and the bottom area where the images show those areas indicated by the yellow outlines at higher magnification. And this is one of the recent studies from Kella et al. Demonstrate the effectiveness of deep learning modules in detecting cancer metastases in lymph nodes. They analyzed about 336 sentinel lymph nodes and 258 non-sentinel lymph nodes using whole slide microscopy with H&E staining. The system achieved 100% sensitivity and negative predictive value for sentinel lymph nodes, ensuring that all true metastatic cases were identified without omission. Although specificity and positive predictive value, as you see here, were lower due to some false positives, but that means that the system really effectively ruled out all metastases. And as you see here, these are representative images, shows that the AI accurately detected the macrometastatic mammary carcinoma from cases with invasive lobular carcinoma, as well as some images from macrometastasis in lymph nodes from a post-neoadjuvant chemotherapy, and even isolated tumor cells in a lymph node from post-neoadjuvant chemotherapy. In addition to detection, these modules can quantify tumor grade, hormone receptor status, subtypes, and recurrence risk with reasonable high accuracy by analyzing the H&E pixels on the digital slides. So as you see, the automated mitosis quantification is also important for reviewing breast tumor and other cancers that require mitosis scoring for tumor. And consequently, this may enable really a new scoring paradigm in the digital era that might replace really high power magnification. On this diagram, as you see, there is a heat map generated over the H&E slides, and when you go on higher magnification, it will generate the heat map of the highest mitosis detection or quantification. And on the image here on B, it will quantify in those green circles all the mitosis that detected by the module. And also, published studies on automated mitosis detection have demonstrated a time saving of nearly 28% in detected and quantifying mitotic figures in breast cancer, along with increased accuracy. So, in this study, they utilized the Cancer Genome Atlas Breast Cancer Invasive Carcinoma dataset, which comprised 100 whole slide images stained with hematoxin and eosin to develop an automated system for Nottingham histological grading to assess the mitotic count, nuclear pleomorphism, and tubular formation using a deep learning based algorithm. The module successfully scored all components of the grading system with impressive accuracy, achieving F1 score of 94.73 for mitotic count, 98.24 for nuclear pleomorphism, and 97.98 for tubular formation. And in this diagram that showed you the summary of the whole slide image analyzed by the AI module, as well as the detection of the heat map of the AI module of all layers, as well as the detection of the pleomorphism and the mitoses. So, besides tumor detection and grading, cancer subtyping is essential for delivering specific prognostic information. Several commercial tools are available that claim to classify invasive carcinoma subtypes and grade DCIS, along with additional features to enhance reporting of breast pathology to patients. So for biomarkers, there are so many to be considered, and perhaps new computational biomarkers will emerge as machine learning modules move toward the discovery phase. And so there are already numerous image analysis tools and that can quantify the most common biomarkers such as ER, estrogen receptor, progesterone receptor, HER2, as well as Ki-67. These technology quantify pathology, immunochemical stains, and automatically quantify the positive and negative staining cells, nuclear staining, or the membrane staining, and this will hopefully show increase in standardization and uphold the accuracy of such quantifications as these biomarkers are used for treatment decision making. At the University of Michigan, we have a systematic approach to handle the breast cancer cases. The process starts with pathologists examining a case and ordering necessary biomarkers like ER, PR, HER2, and Ki-67. This action prompts an order for immunochemistry stains where we carefully select and prepare specific antibody to match the subsequent algorithm we use for case analysis. The prepared case undergoes assembly and thorough quality check and to ensure accuracy before it's scanned using the Roche-Ventana system, and post-scanning these cases managed and transferred to the technologist who uses software to perform quantitative image analysis, generating a report which forwarded to the pathologist who initiated the order. The pathologist then reviews the findings and manually ensure that they agree with them and subsequently report the results to the quantitative image analysis. Ultimately, our final right now report is prepared and sent both to the both patient and the treating provider. And this is one of the recent publication from our department showing that we try to evaluate if the image analysis and simple machine learning contribute to standardizing our practice. So retrospectively analyzed our approach, comparing the image analysis result to pathologists' interpretation of the ER, PR, and HER2. We reviewed about 1,300 cases, breast cancer cases, including different histology subtypes. We focus on the also equivocal HER2 cases and compare with FISH results. We found there are high concordance, above 90% for the ER and PR, as well as the HER2 biomarkers. We found some discrepancy investigated, and the reason for those discrepancies, we found about like 33 cases for the ER, mostly because of the low positive scores, as well as the PR. We really find really slightly difference in the HER2 cases, about just 1% disagreed with the FISH results, which is concordant with the results. So HER2 quantification is critical for deciding an anti-HER2 therapy. Quantifying HER2 is challenging for computer because it requires analysis of stain intensities, circumferential staining, and the percentage of positive invasive tumor cells. However, several tools are available nowadays to support HER2 quantification. These tools have been developed to enhance pathologist accuracy and efficacy. And efficiency, and include not only HER2 immunohistochemical stain methods, but other bright field applications such as HER2 chromogenic staining and dual-ish staining. And also in the recent clinical trial called Destiny Breast 04, the new antibody drug conjugate TXD has shown significant benefits in the treatment of metastatic breast cancer. The treatment shows positive results in both hormone positive and negative cases, which includes triple negative cases. The trial included patients with 1+ or 2+ IHC FISH negative HER2 diagnoses. However, the treatment does carry a potential risk of fatal interstitial lung disease, thus the patient selection is crucial to patient safety. And especially now, with the new companion diagnostics available for the HER2 low classification and emerging computational biomarkers, may be poised to inform us with patient may benefit with receiving these therapies that we would have otherwise missed based on our current methods of testing. So in an attempt to address the issue of inter-rater discordance, we decided to conduct a study. The aim of our research was to compare the scoring of low HER2 by the quantitative image analysis system with the scoring pathologist. And to achieve this, we conducted a retrospective review of 157 cases, and these HER2 IHC slides were scored as HER2 negative, either 1 or 0, either 1+ or 0, by the quantitative image analysis system. And to establish our ground truths, we enlisted the expertise of 2 breast expert pathologists. Additionally, 4 pathologist readers were involved in the interpreting the HER2 IHC, both with and without assistance of quantitative image analysis system. And this approach we used in our study turns into high agreement with the ground truth for pathologists with quantitative image analysis versus quantitative image analysis or versus the pathologist itself. Our study shows that the quantitative image analysis could be instrumental when percentage of stained cells slightly exceed the 10% cutoff used in identifying HER2 low cases. And to illustrate this point, we examined a particular case where the percentage of stained cells was just above these thresholds. So without the quantitative image analysis, 2 of our 4 pathologists scored this case as 0. When we introduced the quantitative image analysis into the evaluation process, the results were unanimous. All 4 pathologists scored the same case as 1+, And this demonstrates the power of quantitative image analysis to help pathologists identify slight staining that may otherwise go unnoticed. Specific instance, we have a case where the ground truth or the consensus is 1 plus, and in the absence of quantitative image analysis we saw variation in interpretation. 2 out of 4 pathologists also scored this case as 2 plus, indicating a higher staining intensity as you see here. Now when we brought the quantitative image analysis to the picture, an interesting shift also occurred. All 4 pathologists were unanimous agreement scoring this case as 1 plus, perfectly aligning with the ground truth. So additionally, this case was found to be also fish negative when we fish it, which is underpin the reliability of quantitative image analysis accurately determining the HER2 status in challenging cases. And this study demonstrates the best example to predict the status of estrogen, progesterone, and HER2 receptors in the breast cancer from the hematoxylin and eosin stain of the whole slide images. The researcher introduced the tissue fingerprints, which is a novel approach that leverage large annotated database to capture the meaningful histopathological features without requiring extensive labeling. By training the model to recognize the morphological differences between patients, the algorithm effectively learned biological relevant patterns associated with the ER, PR, as well as HER2 statuses, and the result demonstrated strong prediction performance with the area under the curve scores of 89% for ER, 81% for PR, and 79% for the HER2 on an independent test set. So research on the tumor microenvironment has been steadily expanding to transition from qualitative assessment now to quantitative analysis. Tools that detect tumor-infiltrated lymphocytes are essential in counting TILs and determining their locations both within and surrounding the tumor. These modules are really robust enough right now to operate in real time under suitable computational conditions, of course, and handle multiple tasks simultaneously as the pathologist examines the image. As you see right now, the key measurements include quantification of the tumor area, the segmentation, and the ratio of tumor to epithelium or to stroma, and the presence of the TILs within the tumor and in the surrounding area, and subclassifying them. The spatial distribution of immune cells, including the tumor-infiltrating lymphocytes, TILs, and their interaction with the tumor cells have been extensively examined. And as you see, these tumors can be effectively mapped, which have really potential impact in the clinical practice. These investigators were able to predict the outcome of the ER-positive breast cancer patients by evaluating nuclear shape, orientation, and spatial relationships. And these are things that really we don't typically do with our own human eyes that might be possible within these tools. In this study that's published by Wang et al., investigated the ability to predict responses to neoadjuvant chemotherapy in breast cancer patients. The result demonstrated high predictive accuracy of HER2 positive breast cancer with area under the curve of about 90%, while the predictive performance for the triple negative cancer was more variable, as you see here, with area under the curve up to 76%. So these findings suggest that the image-based approach is particularly effective for predicting the neoadjuvant chemotherapy responses in HER2 positive breast cancer, though its efficacy is more limited to the triple negative tumor. So, in terms of survival analysis, this study identified the factors a machine learning model considered predictive of high risk or low risk patients regarding their survival. So, by taking a reverse approach, we can examine the features these models use to potentially uncover diagnostic indicators that pathologists may not have recognized. This insight could be valuable in identifying additional characteristics linked to patient survival outcome. So, for example, all these patches were taken from cases predicted to be high risk, while these patches are taken from cases predicted to be low risk. But then excuse me, when only these patches, when you look at these patches in the top, those patches shows high risk patches, which is taken from cases predicted to be high risk. While when you move to those patches and the patches of the cases to be taken from the low risks, it shows that those are low risk patches. But also here, as you see, those patches are also low risk patches. Those patches were within the cases of the high risk as well. Investigators evaluated immune cells, tumor cells, and immune cancer associated regions of interest and showed that the intratumor lymphocyte ratio is a statistical measure of lymphocyte infiltration and was independent predictor of disease specific survival in this triple negative breast cancer cohort. So, when adopting AI in pathology, several key factors ensure effective and ethical implementation. First, the computational system must be robust, featuring GPU acceleration, parallel processing, ample memory, and high storage speed, while supporting framework like, for example, some like TensorFlow, PyTorch, and etc. Efficient cooling and also cost-effective solutions are also essential. Adequate storage involves sufficient capacity, reliable backups, cloud options, as well as secure long-term preservation. So data quality is also critical, requiring high performance light scanner, standardization, as well as well annotated database, because the term the all saying garbage in, garbage out, and you need really sufficient quantity to ensure reliable models. Privacy and security must be strictly maintained. Selecting AI models should be guided by clear analytical goals with a thorough evaluation and validation. Techniques like transfer learning can help with limited data, and more should be interpretable and scalable for future interpretation. Stakeholder feedback is really important from the medical professional, and it is vital in clinical validation. And finally, ethical principle must underpin the entire approach, safeguard patient privacy, and ensuring transparency in managing the data responsibly, and also fostering ongoing multidisciplinary collaboration to maintain high standards and integrity in the AI-driven pathology. I would like to emphasize and share with you that what might go wrong, although I shared with you all the things that really promising from machine learning and AI, but for surgical pathology, the whole slide image is only as good as the glass slide from which it came from the lab. And so, if the machine learning modules are trained without real world data or without any of the pre analytic variables that typically happen in every lab, you might expect a performance on that really on real world data that might not be as high as it claims. So, unfortunately, for a real world state of interoperability, there is still much left to be completed. And the industry and standard organizations are really moving this forward. And certain standards right now do exist, but we are still lacking a lot of seamless interoperable experience. And for example, so far there are multiple proprietary formats that those scanners are generating. uh, there are different image compressions, different color ICC profile that these scanners that are generating. uh, we have various multiple electronic health record system that need to be integrated with the image management system as well as the lab information system. And plus we have multiple machine learning modules architectures right now. That's bring me to DICOM, which is a digital imaging and communications in medicine. It is an international standard to transmit, store, retrieve, print, process, and display medical images information. And this standard has been used for ages, more than 20 years, by our radiology colleagues, and it is the standards format for all the medical images. And fortunately, right now in pathology, we start using this standard format. And in pathology right now, we've been fortunate to have those supplements already implemented within the standards for DICOM. And those are the supplements that's called tile-based pyramid encoding, which technically encodes all these, dividing the large image, which is the whole slide image, which, as you know, it's a pyramid shape in format, and dividing the large image into smaller manageable tiles, and each tiles to have an efficient compression and quick access to those images. So imagine in this picture I'm showing to you, this is a strip and all these pixels are stored on this strip, and also show you all the pixel metadata. Now I'm talking about pixel metadata, as like what is the magnification, what is the compression ratio, what is the ICC color profile. Every single bits of the pixel is already stored in this DICOM format. And not only the pixel metadata that we can store in the DICOM standards, also thanks to the supplement 122, the specimen identification and revised pathology SOP classes, which is technically put all what's called DICOM attributes or DICOM tags that give detailed metadata about the specimens, the benefits of it, which is efficient storage and retrieval, and enhance the metadata integration. And with this, I'm showing to you right now, imagine that you have an image. I'm talking about an image that has all the patient metadata: patient name, MRN, date of birth, sex, date of operation, the accession number, date of report, the all these boxes, all these tags, attributes are stored in this strip within the image, and it's not gonna send by, for example, an XML or spreadsheet. No, it's one single image. And imagine if you can share this image with anyone else, and you can apply machine learning and build a tremendous application or models with these metadata. So in conclusion, the pathologists remain crucial for validating, overseeing, and integrating the machine learning tools. The machine learning automates routine tasks, enhancing pathologist efficiency and enabling a focus on critical clinical activity, which is a great thing. And machine learning drives the creation of new roles such as computational pathologist, data analyst, and imaging specialist. And this concludes our presentation. Thank you so much for attending this lecture, and I'm open for any questions.